Okay. Good morning, everyone. Today we are to see traumatic injuries or trauma. Okay. In that we see introduction about the injuries, etiology and epidemiology, classification, and examination of the traumatized patient. Dental traumatology is a branch of dentistry that encompasses the etiology, that is what is the cause of the trauma, epidemiology, prevention of the trauma, assessment, diagnosis, and management, and post-traumatic sequel for the same patient. Traumatic injuries are typically traumatic injury to the tooth results in damage to the dental and periradical structures. The management and consequences of these injuries are and knowledge of the healing patterns of the tissue is essential. Timely care is an important as the care itself because most adverse post-traumatic sequel are a consequence of a insufficient or inappropriate treatment. Okay. As you can see, there are many causes for this one traumatic injuries. Mostly, fall is 26 to 82%. Then sports, fighting, accidents, child abuse. Okay. Predisposing factors are such as homeless child and the poor socio-economic status. Various habits or various malocclusion due to the various developmental anomalies. Okay. The increased overjet, Angles class 2B1, Angles class 1 type 2, high carriage index. Okay. A palsied child or an abnormal child with abnormal muscle tone, poor skeletal and muscle coordination. Okay. Here we can see age group and cause of injury. First year of life, fall from baby carriages. Before school age, falls, collisions. Small children, playground, bicycle, child abuse. In teenage, sports and fights. Late teens, automobile accidents. And older age group, the automobiles and fights. Great psychological impact on both child and parent due to this trauma. Target for teaching and ridicule. Primary teeth. Okay. Age distribution, primary teeth is 1 to 2.5 years, then permanent teeth 8 to 11 years. Gender significance in injuries. In younger children, there is not much difference between the sexes, that is male and female. Type of play is very similar between boys and girls. In older age groups, boys tend to have more dental injuries than girls because more aggressive play from boys and earlier introduction to competitive sports. That is, average of girls and boys injuries is 1.5 to 1. Categories of trauma, that is intentional and non-intentional. In intentional, suicide, homicides, domestic abuse, war, and terrorism. in non-intentional, domestic, recreational, sports, work, and vehicular. The vehicular is nothing but the roadside accidents. Types of injury are soft tissue injuries, hard tissue injuries. Soft tissue injuries mainly occurs to facial skin, lips, mucosa, tongue, soft tissue and hard and soft palate. Hard tissue injuries are to the hard tissues present in the oral cavity, such as teeth, alveolar bone, and the facial bones on the face. Mechanism of dental injury, that is direct and indirect. Indirect when the tooth itself is struck, and indirect when the lower dental arch is closed against the upper arch. Type of injury for permanent dentition and the primary dentition. For permanent dentition, uncomplicated crown fractures, supporting structures are stable. In primary dentition, primary dentition, luxations, supporting structures are resilient and elastic. Dental location of injury, that is, epidemiological studies have shown that the most common tooth to become traumatized is the maxillary central incisor, maxillary lateral incisor, and then mandibular central incisor. Okay. Extent of trauma can be assessed by four factors. That is, energy of impact. Energy is nothing but mass into velocity. That is, a striking object with more mass and velocity creates a greater impact. Direction of the impacting force. Energy of impact is nothing but the force applied to the impact. Direction of the impact, shape of the impacting object, whether it was a road accident or the any individual fell down on the road or any object struck to the tooth, and the resilience of the impact object. Direction of impacting force is the type of fracture depends on the direction of the force. Shape of the impacting object, that is sharpness, bluntness of the object. According to the sharpness and bluntness, the type of injury is recorded. Resilience of the impacting object, that is hardness, smoothness of the object. Okay, now we'll see classification of the injuries. Actually, this is the most important part in injuries. Uh, why the classification is required for such type of topic? Okay, uh, classification is required because to identify the actual problem, recalling past difficulties with similar cases, ease of references for documentation of the cases, and better treatment and planning of the cases. Okay. Rabinovich classification, it was given in 1956, that is, fractures of the enamel or slightly into the dentine. Class 2, fractures into the dentine. Class 3, fractures into the pulp. Class 4, fractures of the root. Class 5, contaminated fractures. And class 6 is displaced fractures. Comminuted fractures are nothing but the multiple fractures. Displaced tooth is nothing but the tooth itself gets displaced from its socket, and others, enamel fracture, dentin pulp, and root fracture. Okay. Ellis classification, in day-to-day life you have been come across this Ellis classification. Class 1 refers to enamel fracture. Class 2 is dental fracture with or without pulp exposure. Class 3 is crown fracture with pulp exposure. Class 4 is root fracture, and class 5 is tooth luxation, and class 6 is tooth intrusion. Tooth luxation is nothing but the popping out of the tooth from this socket, and tooth intrusion is nothing but the tooth gets stuck into the socket itself. Okay, Ellis and Davis classification. Class 1, simple fracture of the crown involving little or no dentin. This one, simple classification of crown involving little or no dentin. Class 2 is extensive fracture of the crown involving considerable dentin but not the dental pulp. Only the dental, some part of the dentin is involved, pulp is not involved. Okay. This type of fracture, it is class 2 is Ellis and Davis fracture. Class 3, extensive fracture of the crown involving considerable dentin and exposing the dental pulp. This one. Okay. This fracture. Class 4, the traumatized teeth become non-vital with or without a loss of crown structure. This one. This is a non-vital teeth, as you can see the discoloration due to the necrosis of the pulp. Class 5 is Teeth lost as a result of trauma. Due to trauma, the whole tooth is lost. This one. Okay. Classic is fracture of root with or without of the crown structure. This one. Without fracture of the crown structure. Class 7, displacement of a tooth without fracture of the crown or root. No fracture is seen on the tooth, but the tooth is displaced from its original space. Class 8, fracture of crown, en masse and replacement. Here, whole fracture is occurred and the whole en masse is replaced. Class 9 is traumatic injuries to the primary. These are the primary two. Okay, classification by McDonald, Abbey and Lynch. Class 1 is simple fracture of the crown involving little or no denting. Class 2 is extensive fracture of the crown involving considerable denting but not the dental pulp. Class 3 is extensive fracture of the crown involving considerable denting and exposure of a dental pulp. Class 4 is loss of entire crown. Okay. Morelli and Herzberg classification. For subgingival fractures, fracture line does not extend below the level of attached gingiva. Class 2, fracture line below the level of attached gingiva but above the level of alveolar place. Class 3, fracture line below the level of alveolar place. Class 4, fracture line below the level of alveolar place but within the coronal third of the root. Actually, there are many of the classifications. These all classifications you will find into the textbooks. Just understand here and read it into the books. Classification of Anderson. Based on the system adopted by the World Health Organization in the application of the International Classification of Diseases of Dentistry and Stomatology, based on anatomical, therapeutic, and prognostic considerations, can be applied to the both primary and the permanent teeth. Injuries to the hard dental tissue and the pulp, this one, that is crown infarction, incomplete fracture, that is fracture of the enamel without loss of the tooth substance. Okay, this is the incomplete fracture. Here you can see the lines. Okay. Second is uncomplicated fracture. Okay, uh, contained to enamel. This one involving enamel and dentin, but no pulp exposure. Here, enamel and dentin is involved in the fracture, but pulp exposure is not there. Injuries to the hard dental tissues and pulp, complicated crown, involving enamel and dentin and exposing the pulp. Here we can see enamel dentin is totally chipped off due to the fracture and exposure of the pulp has been taken place. Uncomplicated crown fracture involving enamel, dentin and cementum but not involving the pulp. This is uncomplicated fracture. And complicated crown root fracture involving enamel, dentin and cementum and exposing the pulp. As here you can see. Root, these are the root fracture involving dentin, cementum and pulp. Injuries to the periodontal tissue. First one is concussion, an injury to the tooth supporting structure without abnormal loosening or displacement of the tooth, but with marked reaction to percussion. Okay. Second one is subluxation, an injury to the tooth supporting structure with abnormal loosening, but without displacement of the tooth. Here we can see subluxation of the tooth is occurred. Okay. Intrusive luxation is nothing but the tooth goes completely into the socket by fracturing the alveolar bone. This is the socket, as you can see. Tooth should be at this level, but due to the intrusive force, the tooth has gone into the alveolar bone, okay, or alveolar socket. Extrusive luxation, that is partial dislocation of the tooth from its socket. The original part of the original place of this tooth is over here, but a partial subluxation of the tooth has been occurred. Okay. Lateral luxation. Lateral luxation is nothing but tooth is displaced laterally out of the socket by breaking the alveolar bone. That is lateral luxation. Uh, Stipulation or complete avulsion. Complete avulsion is nothing but the removal of the tooth or displacement of the tooth from the socket. Injuries to the supporting bone. Communication of alveolar socket, mandible, N802.2. These are the various types of classification. Crushing and compression alveolar socket found in including lateral luxation. Number two is content to facial or lingual socket wall. Number three is fracture of the alveolar process, which may or may not involve alveolar socket. Plus four is involving fracture involving base of the mandible or maxillary of alveolar process. Injuries to the gingiva or oral mucosa, laceration of gingiva, that is shallow or deep wound in the mucosa, resulting from tear and unusual uh, produced by sharp object. Contusion of gingiva or oral mucosa, that is bruise usually produced by impact from blunt object and not accompanied by the break of continuity in mucosa, causing submucosal hemorrhage. Third one is abrasion of gingiva or oral mucosa. It is superficial wound produced by rubbing or scraping of mucosa, leaving raw bleeding surface. Classification adopted by World Health Organization and modified by Anderson. Coding in the system is based on International Classification of Diseases, that is DCMA. Injuries to the hard dental tissues and pulp by DCMA, that is enamel infraction, enamel fracture, that is uncomplicated crown fracture, the uncomplicated crown and root fracture, uncomplicated crown fracture, uncomplicated crown root fracture, complicated crown root fracture, and root fracture. These are the various numbers used for the classification. Injuries to the periodontal tissue, that is contusion, subluxation, extensive luxation, lateral luxation, intracute luxation, and avulsion. Based on the World Health Organization classification of diseases and modified by Anderson and Anderson, uh, there are many of the classifications. You have to see into this. Main are this Anderson and Anderson, Ellis classification, Ellis and Davis classification. Kindly go through this classification. Dentofacial injury, that is soft tissue laceration, contusion, abrasion. Tooth fracture, that is enamel fractures, uncomplicated crown fractures, complicated crown fractures, crown root fractures, and root fractures. Luxation injuries, that is tooth contusion, subluxation, extensive luxation. Actually, these terms are easy to understand, that's why I'm not going into deep. Example, luxation is nothing but the removal of the tooth. Or in that there are types, that is tooth concussion, just movement, subluxation, some of the tooth is luxated, extensive, that is outside the this one socket, intrusive is inside the socket, lateral is lateral side of the socket, and avulsion is complete removal of the tooth. Facial skeletal injuries are alveolar process, body of maxillomandibular bone, temporomandibular joint. Okay, this is the Basirani classification. Round fractures. They are fracture of enamel and dentin. In that you can see with pulp exposure, without pulp exposure. Second is root fracture. Third is ground root fracture. Alphon classification, that is this classification based on the clinical and bronchic and does not reveal the extent of fracture of amount of dentin exposed. The basis classification on three aspects: clinical state of pulp and dentin as one organ, determination of the treatment. Okay, spinous and arthritis, it's not important for you. Okay, now this is the most important part for you, that is examination of the traumatized tooth. In order to arrive at a quick and correct diagnosis of the problem, sorry, extent of injury to the pulp, periodontium, and associated structures, a systemic examination of the traumatized patient is essential. When the patient is received for treatment of an acute trauma, the oral region is usually heavily contaminated. Okay, in simple languages, whenever patient occurs with the trauma, the area of the trauma is heavily contaminated. All the blood, or if it is fallen, the mud is attached to the same area. Okay. The first step in the examination procedure, therefore, is to wash the patient face using sponge or flowing water if he can gargle. Once this has been done, it is possible to get an initial impression of the extent of injury. Thereafter, a series of questions must be asked to the aid in diagnosis and treatment planning. These questions may include, that is, chief complaint, includes several subjective symptoms listed in order to importance of the patient, note the duration of each symptom. Medical consideration, this is also one of the important facts that the patient may have been medically compromised before the injury or a result of the injury. Not only will these medical issues have an impact on the overall dental treatment, but a medically compromised medical status can be life-threatening. When proper assessment and referral are not made in a timely manner, usually a thorough evaluation is made by a physician. However, the clinician should be aware of the general medical issue that may affect the emergency dental care. A thorough medical history should be taken as soon as possible. In that, we should include the systemic diseases so as to see the condition of the patient for various systemic diseases which can be lead to blood clotting or any asthmatic attacks or any hypertension, in which this injury may lead to patient to any shocks. Different allergies, as we have to use the various medication, allergies to the several medications are also be asked to the patient. Recent hospitalization of the patient should be asked for any particular diseases. Current medication, various current medications are asked for the patient because we can alter our medicine if they are contraindicated with some other of the medication with the currently patient is taking. Tetanus simulation status, where is the various doses of the tetanus simulation has been taken by the patient. Okay, after that we should see essential vital signs, that is pulse, blood pressure. Okay, in pulse, full pale skin, hypotension, tachycardia, perception, mental status changes, shock, that is shock, hypovolemic has to be checked. Decreased pulse rate, hypertension, increased intracranial pressure is to be checked. Increased intracranial pressure is checked when there is any head injury. Okay, with possible aspiration of the removable prosthesis. Uh, it may be possible that patient may engulf the if removable prosthesis present in the patient. Any aspiration of the avulse tooth or tooth fragment should be taken. Coughing, cyanosis, dyspnea, and fever to be checked. Partial or complete airway obstruction is mostly monitorized. Alveolar and orbital fractures are checked. Okay. Potential damage to the cranial nerve and the cranial size. Olfactory nerve, if there is a damage to the olfactory nerve, loss of the sense of smell and apparent loss of sense of taste. For optic nerve, diplopia, that is double vision. Oculomotor nerve, blurred vision is seen. Cochlear nerve, pupils do not react to the light. If there is injury to the abducens nerve, pupils are not equal in size. These are the various types of injury offered to the various nerves and their clinical signs. Trigeminal nerve, area of paresthesia on the face and upper neck, loss of sensation on the anterior tongue. If there is injury to the facial nerve, inability to wrinkle forehead and inability to squeeze the eyes, inability to elevate the upper lip. Vestibular nerve, impaired hearing and inability to maintain postural balance. Glossopharyngeal nerve, difficulty in swallowing. Vagus nerve, abnormal speech with hoarse voice and hypoglossal, inability to produce the tongue, ipsilateral tongue deviation. History of present illness. How did the injury occur?